Assalamualaikum and a very good morning to Dr. Chan and all the members of the pediatric posting. So today me and my teams will presented on virology seminar. So the contents of our seminar today, the first syndrome is infectious mononucleosis and Roseola infantum. The second is mumps, measles, and rubella. The third is varicella and herpes zoster. The fourth is hand, foot, and mouth disease. So the first, the infectious mononucleosis and Roseola infantum will be presented by me, Aisha Humaira, 1813782. So infectious mononucleosis. So this is the outline of my presentation today. Okay, so what is infectious mononucleosis? So infectious mononucleosis is characterized by a triad of fever, tonsillar pharyngitis, and also lymphadenopathy. And it's also known as a glandular fever in the past, and then the term changed to the infectious mononucleosis. Okay, so primarily, the infectious mononucleosis are caused by Epstein-Barr virus. They are responsible about more than 90% of the cases. So the virus is a double-stranded DNA virus and a member of gamma herpes virus. And about 5 to 10% of the infectious mononucleosis-like illness are caused by the cytomegalovirus, Toxoplasma gondii, adenovirus, hepatitis virus, primary HIV, and possibly rubella virus. For the epidemiology, Epstein-Barr virus infects more than 95% of the world's population. These viruses are acquired during the childhood years, is often subclinical, asymptomatic, and indistinguishable from other childhood infection. And less than 10% of the children are presented with the clinical infection, although there are high rate of exposure. And the incidence of the symptomatic infection begins to rise in adolescence through the adult years. So adolescents and adults manifest in 30 to 50% of the cases as a classic triad of fatigue, pharyngitis, and generalized lymphadenopathy. And the syndrome is also seen in all ages, but the peak incidence is between 15 to 24-year age range. And the virus is transmitted primarily via oral secretion, and it also may be transmitted via penetrative sexual intercourse. But as for children, the virus transmitted by the exchange of saliva between from child to another child. So this is the pathogenesis of the infectious mononucleosis. So firstly, virus is shed in the salivary secretion for a prolonged period, about 6 months following the infection. Then the virus gets transmitted from person to person. And then the virus contact with the oropharyngeal epithelial cell, and then the virus will replicate within the cell. So it's responsible about 4 to 8 week incubation period. And then EBV then get released into the oropharyngeal secretion. So after it released the oropharyngeal secretion, it will infect the B cell in the lymphoid tissue in the oropharynx. So it's responsible for the clinical manifestation of the pharyngitis. And then EBV virus induce antibody production, and then it will activate T cell. So T cell will release cytokine interleukin 2 and also interferon gamma that are responsible for the fever. And then the infection will disseminate through the lympho-reticular system. So it's responsible for the lymphadenopathy and splenomegaly manifestation. And then the virus can remain latent in the B cell. So for the clinical manifestation, the incubation period is about 1 to 2 months. The prodromal period lasts for 1 to 2 weeks, and the patient complain of the malaise, fatigue, acute or prolonged more than 1 week fever, headache, sore throat, nausea without vomiting is very common, abdominal pain, and myalgia. Myalgia is not very common. Okay, so the typical feature, as I stated earlier, is the classic triad of fever, pharyngitis, and lymphadenopathy, and fatigue, and also fatigue. The fever, pharyngitis, and lymphadenopathy may resolve in weeks, but the fatigue may get severe and persist for months. Okay, for the sore throat, the history of sore throat is accompanied by the pharyngitis and tonsillar exudate. So if you can see here, the sore throat can be viewed as a white or green exudate, and also it can even be necrotic. For the lymphadenopathy, the lymphadenopathy commonly involve posterior cervical and posterior auricular nodes than the anterior chain. And then lymphadenopathy can become generalized, and generalized lymphadenopathy is distinguish the IM from another causes of the pharyngitis. So lymphadenopathy also peak incidence of lymphadenopathy is within the first week. For the other finding is splenomegaly and also splenic rupture. So splenic rupture is a rare but a life-threatening condition, and other is hepatomegaly and rashes. So rashes is a generalized maculopapular urticaria or petechial rash is occasionally seen. And the picture show the ampicillin rash. So the ampicillin rash is happen when the patient with infectious mononucleosis get treatment for the antibiotic, which is ampicillin. So after the treatment of the antibiotic, about 5 to 9 days after that, they will develop rash. So these are the main symptoms of the infectious mononucleosis.
Just in case you guys get confused, the ampicillin given is not treatment for the mononucleosis. It's just that they present with cough, they present with sore throat, right? So the most common cause of sore throat is they would think it's a strep infection, isn't it? So they go and give ampicillin. So when they give ampicillin, the reaction that you get is that you get that rash. The ampicillin is not for the infectious mononucleosis. It's just that they gave it because they assume that the kid has a sore throat. Understood? You guys understood or not?
Understand?
Yes, doctor.
Faces. If I cannot see your faces, the least you could do is say yes or no, or not, or something. I don't know. Because I don't want you to get confused because your friend said given treatment ampicillin. The ampicillin is not for the infectious mononucleosis. The ampicillin was given because these are kids who get sore throat. So kids who get sore throat, they assume it's a strep infection, isn't it? Or staph infection, isn't it? So they give ampicillin. The knee-jerk reaction is to just give antibiotics, right? So when they give the antibiotics and it happens to be infectious mononucleosis, what happens is that they get a rash after that, which looks like that picture just now. Understood or not? Right? The treatment is not ampicillin. Okay? Okay. Continue.
Okay, so after that is differential diagnosis. So the first is infectious mononucleosis-like illness. Can be caused by the cytomegalovirus, Toxoplasma gondii, adenovirus, hepatitis virus, HIV, or possibly rubella virus. And for this cytomegalovirus and HIV, it's almost not possible to diagnose them clinically to differentiate between them and infectious mononucleosis. So we need to do diagnostic testing to differentiate between them. Okay, for the streptococcal pharyngitis caused by the group A streptococcus. So group A streptococcus also come out with clinical syndrome like fever, pharyngitis, and also lymphadenopathy. But this pharyngitis, they don't present with the fatigue and also splenomegaly. And after that, mononucleosis mononucleosis syndrome and the lymphocytosis also can be because of the drug induced, such as anticonvulsant, which is phenytoin or carbamazepine, or antibiotic like isoniazid or minocycline. And patient with splenomegaly and lymphadenopathy also presented with lymphoma. Okay, for the investigation, so we can do the full blood count to look for full blood count, look for the leukocytosis, lymphocytosis due to the due to the increase of the atypical lymphocyte, and also some of the patient may come with the thrombocytopenia. And second is liver function test most of the patient are elevated of the serum transaminase. But this full blood count and liver function test just to support that this is a EBV infection. But to confirm the diagnosis, we need to do monospot test and serological test. So the monospot test is to detect the reactive heterophile antibodies. And if the monospot test already positive, so we doesn't need more to do the serological test. But if the patient suspected for the infectious mononucleosis, but the monospot test is negative, so we need to do the serological test to detect the antibody against the viral capsid antigen, against the LE antigen and EBV nuclear antigen. So why we need to confirm the diagnosis of the infectious mononucleosis? Because we need to inform the patient about the possibility of the splenic rupture and other complications. For the prognosis, most individuals with primary Epstein-Barr virus infection recover uneventfully and develop strong immunity. But for the complication, the most severe complication is the splenic rupture. And the rate of the splenic rupture is less than 0.5% in adult and may be lower in children. The second is airway obstruction. So airway obstruction can manifest as a stridor and also can interfere with the breathing. So airway obstruction is caused by the swelling of the tonsil and oropharyngeal lymphoid tissue. And another uncommon complication is severe neurologic manifestation with headache, seizure, and ataxia, and also meningitis. And some of the complication result from the EBV induced antibody against the red blood cell and also white blood cell. So it lead to hemolytic anemia and also aplastic anemia. Okay. Another uncommon complication are myocarditis or interstitial pneumonia, pancreatitis, parotitis, and orchitis. Okay, for management, the Epstein-Barr virus rarely require more than the supportive therapy. So there is no specific treatment for the infectious mononucleosis. So the patient are encouraged to get rest, to take the adequate fluid and nutrition, and for the symptomatic treatment, we can give the antipyretic, acetaminophen, or non-steroidal anti-inflammatory drug to treat fever, throat discomfort, and malaise. And for the patient with complications such as airway obstruction, we can administer corticosteroid. And antiviral therapy is not recommended because it is proven that antiviral is not cause no effect on the latent infection, and also no ability to cure the infection. And the patient also encouraged to avoid excessive physical activities during the first 2 to 3 weeks of illness or why splenomegaly is present to reduce the possibility of the splenic rupture. So that's all for the infectious mono nucleosis. The second is Roseola infantum or Exanthum subitum. Okay, so the Roseola infantum is a clinical syndrome that characterized by 3 to 5 days of the high fever that then resolve abruptly. And then after the fever, it is followed by the development of a rash. So Roseola infantum is also known as the exanthum subitum, which is sudden rash or a seeds disease, because Roseola infantum is the seeds of the traditional exanthum of the childhood. So primarily, it caused by the human herpes virus type C. So human herpes virus type C is a large enveloped double-stranded DNA virus and a members of the herpes virus family. And other causes, which also common causes, is herpes virus type 7, enterovirus, adenovirus, and parainfluenza virus type 1. So for the epidemiology, okay, transplacenta antibody, they protect most of the infant until the 6 months of age. So the incidence will increases as the maternally derived antibody levels decline. So the prevalence of the Roseola infantum is 95 of 95% of the children are being affected with herpes virus type 6 by 2 years of the age, and a peak prevalence are between 7 and 30 months. And it also occur equally in boys and girls. And it is transmitted by the shedding of the virus in the saliva or respiratory droplet of asymptomatic adult or other children. Then, for the pathogenesis, so we know the infection begin after patient come in contact with the respiratory secretion from adult or other children that shed the virus. So once in the body, the virus will attach to the antigen presenting cell, which are dendritic cells. So this cell, they process the antigen and then they present the antigen at the cell surface. And then when the virus are attached to dendritic cell, they will activate the dendritic cell, and then the dendritic cell will migrate to the lymph node. So at the lymph node, the dendritic cell will interact with the T cell, CD4 T cell. So when the dendritic cell and CD4 T cell interact, the virus will get ingested by the T cell. And then the virus in the T cell, it will replicate, and it replicate most effectively and in the T cell. So in T cell, it will transcribe and translate it to a new virus protein and then package into the new virus. Once the new virus is ready, the T cell will undergo apoptosis and will get destroyed, and the virus will infect other neighboring cells. So this virus also can infect a broad range of the cell type, which are monocyte, natural killer cell, dendritic cell, astrocyte, and megakaryocyte. And this virus also enter the cell via interaction with CD4/6, which give the virus broad tissue tropism. So after the primary infection, herpes virus type C will remain latent in lymphocyte and monocyte, and it will get reactivated in immunosuppressed and immunocompromised patient. For the clinical manifestation, as I said earlier, that clinical cause of this syndrome is 3 to 5 days of fever that resolve abruptly and followed by a rash. So during the febrile phase, so it begin at a fever that may exceed 40 degrees Celsius, and the fever also lasts for 3 to 5 days. And during the febrile phase, it also accompanied by another clinical manifestation such as palpebral conjunctivitis, edematous eyelid, acute otitis media, Nagayama spots, rhinorrhea, cough, vomiting, diarrhea, bulging fontanelle, and cervical postauricular or occipital lymphadenopathy, which is common because 1/3 of the patient have lymphadenopathy. Next, after the febrile phase is a rash. Rash will develop. So the rash is a maculopapular rash. It a faint pink or rose color, as you can see in the picture. It is a non-pruritic rash. It's a 2 to 3 millimeter morbilliform rash on the trunk. It begins on the trunk and neck, and then it will go to the extremities and face. The rash usually lasts for 1 to 3 days, but it occasionally might come and go within 2 to 4 hours. So, the differential diagnosis for this condition, okay, for the rash, it may be mistaken for the rubella, but if you look at picture here, the rash of the rubella begins in the face and then it will spread down to the body. And for the rubella also have the complete spot, and enteroviral infection cause the hand, foot, mouth disease. This will be explained by my friends later. And erythema infectiosum, the rash of erythema infectiosum are predominant at the cheeks, and the scarlet fever cause the sandpaper-like rash. And then it also can cause by the drug allergy, because when you take when a fever, when you have when the child have fever, so when they take drug, so because of drug allergy, the child will develop rash. Okay, and then for the fever and pyorrhea, it may the differential diagnosis, it may also mistaken for the urinary tract infection, because urinary tract infection also come out with fever and also pyorrhea. So there is need to do further analysis like urine culture on that. Okay, for the investigation, so this syndrome is diagnosed clinically based on the characteristic features. So characteristic features is fever for 3 days that resolve abruptly and followed by the development of rash. So the laboratory finding is seldom necessary, but you can do a full blood count, because the patient have low mean of the neutrophil lymphocyte, so patient have neutropenia, and also some of the patient have thrombocytopenia. And we also can do urinalysis, because patient also come with dry pyorrhea. And to confirm the diagnosis, we need to demonstrate the replicating virus in the blood, in the patient's blood. So we need to do PCR to detect the viral DNA. Other than that, we can also do serological tests to measure antibody that against to herpes virus type C and herpes virus type 7 concentration. And also viral culture. Viral culture is a gold standard method to document active viral replication. But viral culture is really expensive, time consuming, and not readily available. It only available in the research laboratory. Okay, for the prognosis, roseola is usually a benign and self-limited illness, and most children with roseola recover spontaneously without sequelae. For the complication, the most common complication, and about 50% of the patient come out with the complication, with this complication, which is seizure. So seizure is often occur during the febrile illness, because it associated with the fever. And then another complication is aseptic meningitis and encephalitis. Encephalitis can occur in normal patient, or also it can occur because of the reactivation of virus in immunocompromised hosts. For the management, so in most cases, roseola is a benign and self-limited disease. So there is no specific therapy. And for the supportive treatment, for the fever, we can give the antibiotic. So we also need to maintain hydration because patient also come with diarrhea, some of the patient. Okay. Then rash also resolve without treatment. And for the immunocompromised host, ganciclovir or foscarnet can be considered. Okay. So this is my references. Okay, that's all from me. Is there any question?
Can I ask?
Yes.
Okay. How to differentiate between rubeola and rubella?
Rubella and rubella.
What's the difference?
Rubella is measles. I think my friend later, Ain will presented on this rubella and rubella. But if rubella, the rash begins on the face and then spread down to the body. So for the rubella, it has complete spot. So that is the features of the rubella. So if you detect the complete spots, it may be
And how about the roseola? Roseola.
roseola.
Is it
Roseola
something?
infantum. Roseola is this disease, right? Roseola infantum.
Okay.
So,
Is it what's the? Is it also has a rash? Or is it?
Rubella, after this will be a rubella presentation. Why don't you listen to the rubella presentation first? Roseola infantum disease. Okay, so the rash looks like the tips of the tip got slapped. Okay, so why don't you just wait for the rubella presentation first?
All right.
okay. If there is no more question, I will give to my friend to present.
All right. Thank you.
Okay, good morning, everyone. My name is Nurul Ainadia, metric number 1811924, and I'll be presenting on measles, mumps, and rubella. So, overall, these are what I'll be talking about, where I'll be focusing on the measles, mumps, and rubella equally. Okay, first of all, the MMR vaccine. So it is a combined 3-in-1 vaccine where we combine antigens from 3 different viruses, the mumps, measles, and rubella, and we put into a single bottle or vial to be administered to children as a single shot. So this is actually to decrease the amount of injection into the children. And also when it is given at 1 year of age, and also the second booster dose at 6 to 7 years of age. And it is usually given at the arm for older children and thigh in infants as single injection. And since MMR viruses are a common cause of childhood illnesses, that's why it's important to have this shot. And it is also important that we need a coverage of more than 95% to ensure the disease continues to decline. Now I'll be talking about measles, also known as rubella, rubeola, or also known as campak in Malay. So it is a highly contagious illness caused by a virus that replicates in the nose and throat of the infected child. And it is also characterized by a typical prodrome followed by a maculopapular rash. So what are the causes? So it is caused by a single-stranded virus in the family of Paramyxoviridae and also the genus Morbillivirus with one antigenic type. So with the single serotype, that's how usually people have lifelong immunity in any individual who had the disease. And humans are the only host as it is transmitted by droplets or the airborne route. So the transmission is through the respiratory tract or conjunctiva, and it is actually highly communicable from 4 days before the rash up to 4 days after its onset. So the epidemiology, it has a global distribution where actually the incidence has reduced with the introduction of immunization. However, there are in some countries or places where the incidence has increased due to the decreased amount of unvaccinated people. So in many developing countries, measles remain as one of the leading cause of childhood besides overcrowding or malnutrition. And it occurs almost exclusively in children because infants less than 6 months are partially protected by the maternal antibody. And and it remains endemic in regions of the world where vaccination is not available and is also responsible for almost 1 million deaths annually, this measles. Okay, and also in Malaysia, we had several cases of measles, such as in 2017. They mentioned that Malaysia had a good immunization program with almost 95% coverage. However, they still found that almost 1,500 children were denied immunization by their parents. So this is very important. And also in Kuala Ko, they detected a large amount of positive cases for measles in 37 people. So 37 positive cases among the orang asli in Kampung Kuala Ko. And the main factor of this spread is because they had a low coverage of MMR immunization. And also in 2020, it was shown how Malaysia can see a drop in cases from 1,958 to 1,077 last year. So a significant case drop. Okay, what are the clinical manifestation? The incubation period is 8 to 12 days from exposure to symptom onset, but it has an average of 14 days from exposure to the rash onset itself. It also has two distinct phases that we can notice, which is the infectious stage and also non-infectious stage. So the infectious stage, we have the prodromal phase, where it is usually occurs for 3 days. So the main important thing is the fever, the 3 C's, which is cough, coryza, and conjunctivitis. And we also have ananthem and eruption in the mucous surface. And the child can also present with miserable or ill-looking and also have malaise, headache, and irritability. So the prodromal signs is the Koplik spots, as Aisha had mentioned before. Here are the Koplik spots. So it is pathognomic, which is characteristic in this disease itself. So we can see the grain white, sand grain sized dots on the buccal mucosa opposite the lower molars here. Okay, this is Koplik spots. And next is the non-infectious stage. So in this
but Koplik spots very difficult to see is at the beginning of it. So day 2, day 3, if you miss it, you miss it. Okay? Continue.
Okay.
I know you're going to confuse yourself. Never mind, later you finish this first.
Okay. Okay, so next is the non-infectious stage. So we still have the classic 3 C's, the cough, coryza, and conjunctiva, but we also have the high-grade fever in this stage. And then this is where we have the discrete erythematous maculopapular rash here. So these are the rashes, and the rashes usually appears on day 3 and day 4, and it initially appears on the forehead, nape of neck, which is behind here at the hairline. at the hairline. And as the rash fades, in the same pattern as it appears, it undergoes the brownish discoloration and also desquamation. So this is the rash. And it usually appears on day 3 or day 4 after the onset of fever. Okay, and the complications. The complications are usually caused by the extension of inflammation by the virus, the secondary infection of the damaged tissues, and also the aggravation of existing malnutrition. So this is how most of the complications are caused. And the most common complication is otitis media. And also we can have bronchopneumonia, giant cell, and pneumonia is usually caused by the secondary bacterial infection. So for example, by streptococcus. And then giant cell is usually seen in impaired cell-mediated immunity. So this is usually fatal. And deaths caused by measles usually result from bronchopneumonia or encephalitis. And they also have a higher risk, especially with patients with malignancy, severe malnutrition, less than 5 years old, or if they are immunocompromised. Okay. Next is the differential diagnosis. So what is diagnostic for measles is they have the constellation of fever, rash, cough, and also conjunctivitis. Even if the Koplik spots is phthalmonic, which is very characteristic of measles, but they are not always present at the time rash is most pronounced. Because if you remember, the prodromal phase usually occurs for 3 days, and then after that, after day 3 or day 4, only the rash appears. So that's why it is hard to recognize the Koplik spots. And the rash must be differentiated from these different types of causes, as Aisha explained just now. So rubella, roseella, adenoviral infection. Okay. And investigation. Diagnosis is usually done by clinical diagnosis or serology, such as a rise in the IgM antibody titer, or even PCR, because the routine laboratory findings are non-specific and don't aid in diagnosis. However, if we do a complete blood count, leukopenia is very characteristic for measles. And then for the management, isolation and hospitalization is very important because it is contagious. And then mostly it's symptomatic treatment with no antiviral therapy unless if the person is immunocompromised. So we have oral rehydration to maintain the hydration and nutrition. We can give antipyretics to relieve the fever, or also give vitamin A for in developing countries that may modulate immune response, because vitamin A has shown and is also suggested by WHO to improve the infant's outcome. So the prevention, most importantly, is the MMR vaccine. Okay, next is mumps. So mumps is also known as bagok. It is highly contagious infection of the parotid glands. It is self-limited and usually characterized by fever, bilateral or unilateral parotid swelling, and also it remains endemic in the rest of the world. Okay, the cause is the mumps virus, which is a single-stranded RNA virus in the family Paramyxoviridae with the genus Rubella virus. So the virus also exists as a single immunotype with humans as the only host. So epidemiology, it occurs more often in spring and winter months during the pre-vaccine area, but it still has a worldwide distribution, prevalent in the crowding and urban community. But similar, it has declined due to the MR vaccine introduction. And it also spreads from person to person by respiratory droplets, and is predominantly in childhood or school age, where 90% rarely in infancy due to the maternal antibody. So even in Malaysia, in August 2018, first, we had the mumps happening in Ipoh, Perak, where most of the clusters, 75 clusters of the mumps were reported nationwide, and 59 were actually detected in schools. And that's how we had the Kajang school closed due to severe outbreak of the mumps, where 70% of the students were infected, including the teachers. Okay, so the clinical manifestation for moms, the incubation period is between 12 to 25 days, and it ranges from asymptomatic or no specific symptoms to typical illnesses of pericarditis. So the prodromal symptoms usually last from 1 to 2 days. So we have the fever, headache, vomiting, achiness, and so on. But pericarditis is what is most prominent in moms, as you can see here in the child. So it first begins unilateral, and then it becomes bilateral in more than 70% cases. Okay, and that's how we can detect moms. And usually a rash is rarely seen in moms. So that's one of the most important difference. Okay, and next, these are the complications. The most common complication is meningitis, because meningitis with or without encephalitis or even any gonadal involvement. And the rest are uncommon, such as conjunctivitis, optic neuritis, pneumonia. Pancreatitis is also not that common for a complication. Okay, and differential diagnosis, we must differentiate with the different causes of pericarditis, such as these viruses. And then we have the purulent pericarditis, usually caused by Staphylococcus aureus, which is usually unilateral. And then with some mandibular or anterior cervical adenitis, or even non-infectious causes that can cause parotid swelling. Okay, next is investigation, similar, where the diagnosis is done by clinical findings, or history of pericarditis must be at least 2 days or more. And then we must confirm the presence of the pericarditis. And usually we can see it in the elevated serum amylase or leukopenia with a relative lymphocytosis. Okay, but serologic test is the most simplest test that can be done. Okay, since viral isolation can also be confirmatory. Next is management. It is usually symptomatic management, which is to decrease the pain of even the complication, such as meningitis or orchitis. And then we can also do pain relief with analgesics, must maintain adequate nutrition and mouth hygiene. And also there's no specific antiviral therapy for moms. And the prevention is similar, which is MMR vaccine. Okay, next is rubella, German measles, or also known as the 3-day measles. So it is a common communicable disease, often occurring in the endemic waves, and it usually affects school-age child, adolescent, and young child. Okay, what are the causes? It's caused by a single-stranded RNA virus in the Togaviridae family, and it is moderately contagious. So not highly contagious as previous. And it also has a single serotype with lifelong immunity. So, and humans are the only natural hosts. So how is it transmitted? It is transmitted via the respiratory droplet and transplacentally. So there's two ways. So the first, it is most contagious through the direct and droplet contact with nasopharyngeal secretions. And the second, transplacentally, it is how infection in the utero results and causes the congenital rubella syndrome, where I'll talk about it after this. So first, the epidemiology. So it usually occurs in spring with epidemic cycles occurring to 6 to 9 years, and approximately 25 to 50% are subclinical, where they are not severe enough to present with a definite symptoms. And even in the United States, fewer than 20 cases of rubella occur, and outbreaks are usually in the non-vaccinated groups from imported cases. And they also have the transplacental antibody to protect during the first 6 months of life. So what are the clinical manifestation? First, the incubation period ranges from 14 to 21 days. So it is infectious from 1 week before and after the rash. So the symptoms, they usually present with mild catarrhal symptoms here of the prodromal phase. However, it's important to note that sometimes it may go unnoticed because it looks like a it is very mild, such as the low-grade fever, malaise, headache, and then they will present with lymphadenopathy, so retroauricular, posterior cervical, even posterior occipital. Okay, and then next it is accompanied by this erythematous maculopapular rash, where it's discrete. So the rash, as Aisha said just now, the rash usually begins from the face, and then it rapidly spreads throughout the body, and may cover with discrete erythematous macules. Okay, and the rash will only fade on the trunk, and then suddenly the rash will disappear rapidly. So this is the rash. And then next is the forehammer spots that occurs in 20% of patients. So this is the petechial lesion on the soft palate, if you can see at the top of your mouth. And then this is only suggestive, but it may appear before the rash. So the forehammer spots can appear first, then only the rash. So yeah, but this is rare since only 20%. Okay, next is the complications. The complications is actually rare, other than the congenital rubella syndrome, because it is uncommon in patients and generally not life-threatening. However, encephalitis is the most serious complication, but most patients actually recover completely and deaths rarely occur. Okay. Next is the congenital rubella syndrome. So this is an illness in infants that results from the maternal infection with the virus, with rubella virus during pregnancy, and usually during the first trimester or first month of pregnancy. So we know that it's transmitted transplacentally, and it reaches the fetus via the emboli of infection. Okay, however, if it occurs during early pregnancy, there are serious consequences, such as miscarriage, we have stillbirths, or even birth defects in infants. Okay, so this is the classical triad of rubella, of the congenital rubella syndrome. So we have the cataract, we have the cardiac abnormalities, and deafness. And deafness is one of the most common symptoms that we can see in this our patient. And also we have developmental delay, growth retardation, and so on. It is important to note that it is preventable with the vaccination, because in UK it is rare since the MMR vaccine is introduced. So as we seen, they also have rashes. The rash must be differentiated from the cause: measles, roseola, and so on. And how do we investigate? So diagnosis is confirmed by serologic testing for example, IgM, or even an increase in fourfold IgG. So here, the antibody titer, we can do tissue culture, viral isolation. However, it's important to note that routine lab is non-specific and doesn't aid in diagnosis. And diagnosis of the maternal infection must be confirmed serologically, since clinical diagnosis is not reliable in maternal infection. And the management is also similar, where there's no effective treatment and we depend on the symptomatic management. So we have antipyretics for the fever, antihistamines to control the pruritus, and no antiviral therapy. But it is also important to maintain the hydration. And prevention is similar, is by the MMR vaccine. So these are, as Aisha has explained just now, the differences between rubella, and also roseola infantum. So rubella, remember the coplic spots and rash from the hairline, and then it spreads to top and then to downwards. And then rubella, we have the forehammer spots on the soft palate on the top here, and also lymphadenopathies. And then lymphadenopathy here. And then roseola infantum, we have the rash on the neck and trunk. Okay, next, this is the summary table that I did.
And go back to that. See, just now this is the reason why Hanum got confused, right? Yes, Hanum.
Yes.
That's the picture why you got confused, right?
How to differentiate
Number
between
one.
those?
Wait, stop. Now, number one. Whenever you have things of similar names, don't attempt to memorize them all at the same time.
Okay.
Okay?
Alright.
Number two. Before you have learned each condition individually, don't get yourself confused. What should you do in this kind of situation? Learn them one by one first, true? Right? You learn them one by one first. In the first place, I didn't realize this is like, I wouldn't ever put it there because how many of you know measles as rubiola? Everybody, video, face. I want to see your faces up now. Hands up. How many of you know measles and rubiola before this presentation? Hands up.
I don't know, doctor.
Isn't it?
No.
Right? So all of a sudden from rubiola, rubella, rosella, you're going to confuse yourself. True? What's the first thing you should do? You should learn each individual disease by itself first. True or not? Right? Once you've learned it individually, then you realize that, hey, all of this is fever and rash. All of this is fever and rash, isn't it? Everything in this presentation by 4 people will be about fever and rash, true? Then what do? You sit down, you write it down, incubation period, symptoms, rash, how the rash spreads, how the rash looks like, what's the differences. That's how you differentiate, isn't it? By the way, sorry, slap cheek disease is parvovirus. I mixed it up just now. So measles is rubiola. Don't bother memorizing rubiola, just remember that it's measles. Okay? At the back of mind, yala is rubiola, but when you say it out, you say it as measles so that you don't get confused by saying rubiola, then you say rubella. And then say rubiola again, then you say rubella. It's confusing yourself unnecessarily, true? Okay, so you learn it as measles first. By the way, measles and rosella, all the one in the middle, the kids with rosella, they tend to be, the differences is that the rash pops out when the fever resolves, right? And the kids tend to be a bit happier. If you look back at, who was the first presenter just now?
Aisha.
If you look at Aisha's pictures just now, the picture with the kid with the rosella infantum rash looked very happy, right? He was smiling, but then the whole body was red, right? So that is rash, that is fever resolve, rash, kid generally happy. Measles, fever, day 3. Hey, don't flip. Don't flip the thing. Measles, fever, day 3, day 4, rash popped out, kids feel miserable. Right? The other symptoms are still there. Right? That's why also if kids are still miserable. And then also the distribution of rash. If rosella infantum, it starts from the trunk, goes everywhere else. If it's measles, cephalocaudal, isn't it? Head all the way down. Right? Measles, you get topic spots, very hard to catch. It's early. And then you get post-measles staining, right? You don't get post-measles staining with rosella infantum. Generally, rosella infantum, the kids are happier once the rash popped up. With measles, the kids are miserable. Honestly, don't even remember that measles is rubiola. You will just confuse yourself. Okay? Rubella is German measles is totally different from measles. The only reason it's called German measles is because the physicians who found out about it were German people. But it's totally different, right? The only thing similar about it is that it has rash. That's about it. Okay. That is why three presentations have the same slide. You know, don't confuse yourself with this slide. Okay. Next. What?
Okay. So the rest, as Dr. Chan mentioned, is to differentiate between the course, the clinical presentation. So I made a table here to observe it. Okay. And differentiate in complication, in DDX, and also investigation and management. As you see, most of them are actually similar from the investigation to management. Okay, and these are my resources. Thank you. Any questions? Okay, so if no, we'll move on to the next presenter.
Okay. All right. I'll continue the presentation with varicella and herpes zoster. I'm Syosha Binti Maknawi, 1812-628, will be presenting on varicella and herpes zoster. Okay, so basically this is my table of content. Okay, so first of all, I'll be presenting on introductions. Okay, first I will introduce what is varicella and zoster. Varicella is the chicken pox, or in Malay we call it cacar. It is the manifestation of primary infections of varicella zoster virus that result in a lifelong latent infections of the sensory ganglion neuron, while the zoster is the shingles, or in Malay we call it kayak. It is a manifestation of the reactivated latent infection of the endogenous varicella zoster virus. So this is the etiology, the causal agents, the varicella zoster virus, VZV. It is a human alpha herpes virus 3, which one of the 9 herpes viruses that known to infect the human, which human is the only reservoir for this virus. It is spherical in shape and around 150 to 200 nanometer in diameter. It is an enveloped double-stranded DNA virus, and usually for the mode of transmission, this virus can be transmitted through airborne or the contact or any vertical transmission into the mucosa of upper respiratory tract, conjunctiva, or any skin lesion. For the epidemiology, chickenpox or the varicella is a very common disease, especially in children. And incidence of adult chickenpox will have a higher rate in the tropical and semi-tropical climates countries compared to countries with temperate climate like the USA and Europe. For herpes zoster, there's not so many study, but there is a well-documented study in the USA about epidemiology of herpes zoster, which approximately around 95 to 99.5% adult age more than 40 will have the antibodies towards the VZV, and almost 4% of the patients will develop a recurrent episodes of the herpes zoster. Around 10 to 15 cases of herpes zoster in USA will complicate to herpes zoster ophthalmicus. However, this herpes zoster is very rare in children and young adults, except for the immunocompromised group. And the incidence will usually increase with age. Usually people more than 50 years old are more susceptible to get this herpes zoster. And generally, there is no sex to them.
What happened? Wi-Fi cut off, is it?
Tak sengaja left kot. Dia tertekan je.
Hello?
Hello, dengar.
Okay. Okay, sorry. Okay, moving on to the pathophysiology. Okay, first of all, the virus will enter through the oral mucosa or any skin lesion, and it will replicate in the epithelial cell. And then it will go to the lymph nodes, and this it will cause the primary infections. Okay, at this stage, it has two stages, where the first stage known as primary viremia. During primary viremia, it will infect the reticular endothelial system, such as the liver. And the next stage will be the around 2 weeks after that, which the virus starts to infect the T cells, known as secondary viremia. Okay, then it will bind to the receptor on the skin, and once the T cells reach the skin, it will release the virus. After release the virus, it can infect the keratinocytes, which then it can spread through the skin directly from cell to cell. And sometimes it can fuse together forming a zinc cell. The uninfected cells will start to secrete interference alpha and beta, which it is mainly to inhibit the viral protein synthesis and also protect the cells from infection. This will result in the tiny lesion on the skin that are separated by normal areas on the skin, known as varicella or the chickenpox. Another one, after the release of the virus by the T cells, aside from infecting the keratinocytes, it can also infect the sensory neuron in the skin, where it can traverse retrogradely to dorsal root ganglion or the trigeminal ganglion if it's in the face. But by the action of the adaptive response in our body, most of the virus will be eliminated. But they will my goodness. Okay. Hello.
Dengar Sasha.
Alright. Sorry. Okay. For okay. After years, it can be due to the immune system because of the aging, because of the prostate, the populations of the virus. The reactivated virus can traverse retrogradely through the sensory back to the skin, and thus it can cause what we call as shingles. Okay. Next, for the clinical features, okay, so this is the varicella zoster or the chickenpox. The classic symptoms, the rash will turn.
I think her connection It's a bit slow.
Okay.
Saya boleh tolong share screen kalau nak.
Lain slow kan Syazwa?
Okay. Sorry. Okay. Alright. Okay. Can you see my slide? No.
Dengar.
Alright. Sorry. Okay. In the next, for the disease onset, we have the triad, the rash, malaise.
Hilang lagi.
Sini line dia.
Who's the fourth presenter?
Rahimi.
Rahimi start dulu.
Okay, Doctor.
Let Sasha settle her connection for a while first. Rahimi, you start first.
Okay. Everyone can hear me right?
Yes.
Yes.
Okay. Assalamualaikum and hi everybody. I'm supposedly the last presenter, but I will cover Shasha. I will presenting about the hand, foot and mouth disease. And my name is Aiman Rahimi bin Jamil, metric number 1810873. Okay, first of all, about the introduction. Okay, hand, foot and mouth disease, or short form is HFMD, is usually a typical benign and common illness that occur in the children or infants, which characterized by the rapidly ulcerating vesicle in the mouth and lesions, which is usually vesicular on the hands and feet. HFMD is usually caused by systemic infection with human enteroviruses, which includes from group enteroviruses, Coxsackie viruses, ecoviruses, and polioviruses. HFMD is one of the most recognizable virus exemptum in children and infants. Okay, for the epidemiology of HFMD, hand, foot, and mouth disease generally is a common and self-limiting disease among children and infants. It occurs worldwide and multiple outbreaks are reported usually in the schools, daycare centers, and other crowded places such as military installation in a large communities and others. In temperate countries, usually most cases reported in summer and fall, while in tropical areas, such as in Southeast Asia, is usually occur in the rainy season. We can see here it increase the possibility that HFMD occur is related to the global climate change. Uh, uh, HFMD can occur to anybody, but is usually common in children younger than 5 years old. It's become an important public health disease due to its high tendency to cause large outbreaks and deaths among children and infants. And it's also an endemic disease in Malaysia with multiple outbreaks that have happened, for example, in Sarawak in 1990s. For the etiology, uh, multiple enterovirus serotypes can cause HFMD, but the most common is the Coxsackie virus A type 16. Other serotypes such as A5, A7, A9, and others. For enterovirus 71 is a chronic, rare cases and neurological related with CNS manifestation. For the mode of transmission, HFMD is moderately contagious. A person with the HFMD during the first week is usually the most contagious. It can be spread by person-to-person contact, having contact with the contaminated surface or objects, the nose and throat discharge from saliva, fluid from the blister, and stool. For the pathogenesis of the HFMD, is occur when the human enteroviruses by the oral injection from the fecal route, and then when it's enter the body, once it's ingested, the enteroviruses will replicate in the oropharynx and then pass into the bowel, then replicate here, and it will then move to the lymphatic tissue and replicate there also. And at this site, it can will lead to primary viremia, where it disseminates in the blood and infect other side of the body, such as uh, the spleen, and and if is ongoing, further replication and dissemination at that site will lead to a secondary viremia, which will lead to disseminate to other side of organs such as heart, lungs, lymph, and others, brain and brain. And then the viral will be excreted in pharynx and feces for weeks, and it will continue the cycle. For the clinical features of the HFMD, the patient typically presents with complaint of mouth or throat pain or refusal to eat due to the oral anatomy that I will explain later. Other clinical features the patient may present is such as the fever, loss of appetite, vomiting, abdominal pain, occasional diarrhea, and on physical examination, we can see oral ananthem and exanthem. For the serotypes, enteroviruses 71, the patient may present with central nervous system manifestations such as meningitis, encephalitis, and others. Okay, first of all, I will explain about the oral ananthem. Oral ananthem is most commonly can be detected at the tongue and buccal mucosa. Less commonly in the gingival groove and on the soft and hard palates, and occasionally on the uvula, lips, and tonsil. The oral ananthem, first it begins as erythematous macules, and then from there it will form vesicles, and around the vesicle there is a thin halo of erythema. The vesicle then will rupture and form a superficial ulcer, which usually painful, with a grayish yellow base and an erythematous rim. Uh, this here, for example, the pictures, we can see here there's a multiple small ulcer that present on the tongue. And the second picture here is the ulcer is present on the oral mucosa. And next is exanthem. Exanthem can be seen usually involve the hands, at the feet, buttocks, legs, and arms. The lesions can be macular, maculopapular, or vesicular, but all of the three features may be present in a patient, in the patient. The vesicle, which come from the macula or maculopapular, have a thin wall which contain a clear or turbid fluid and are surrounded by also by a thin halo of erythema. The lesion is usually non-pruritic and not painful. Here the picture, we can see here the lesion, which is at the foot, at the hands, the vesicles surrounded by thin halo of erythema. This is maybe macula or maculopapular at the hands. Okay, next. Oh, for the diagnosis of HFMD, uh, it's met. It's usually clinically diagnosed by looking at the sign and the symptom of the patient, and usually most of the time, the laboratory test is not carried out unless if the in some cases if we are uncertain of the cause of the rash. For example, most of the time, oral anentum and exanthum will present, both will present in the patient. But if only the oral anentum or only the exanthum is present in the patient, we can do virus culture by collecting the patient's throat, blister offices, or in other conditions. For example, if the patient manifests with central nervous system, we may consider the patient was infected by enterovirus A71. For the differential diagnosis, I have listed some of here, and after this there is also some pictures that we can differentiate between HFMD and all of this disease. Okay, we will go first, herpes simplex gingval system. The first two, which is the herpes simplex gingval system and Aptulus ulcer. Uh, Two of these, it will present with mouth ulcer. So to differentiate between these two and HFMD, usually herpes simplex, the gums of the patient are febrile and can bleed easily, while Aptulus ulcer, the ulcer is usually painful, round, and have yellow-gray appearance. For Hepangina, the ulcer only limited to the oral cavity only, and without any skin involvement, without any exanthum lesion. For varicella, I think we have discussed before, the exanthum appear in scrubs and is usually pruritic. For erythema multiforme, the lesion have a target or bull's-eye-like appearance. We can see here. And next, in the contact dermatitis, the rash is usually papular, erythematous, and pruritic. And history taking for this disease is important, maybe because maybe the patient has allergic to something that caused the dermatitis. And next is the scabies. We can see the appearance of the rash is scaly, red blotches, and small silver lines present, and is usually itchy. And lastly, the insect bites or papilla urticaria is usually papular pruritic lesions. And in this picture, there's a breakfast, lunch, and dinner sign, which is a sign of bed bug bites. There's different three different lesions that caused by the same bug. For next is the complication. Usually the complication for HFMD is usually rare, but the most common complication is dehydration due to the mouth ulcer, oral anentum, which is usually painful. So the patient will have a hard time to swallow some liquid and may cause a dehydration. For fingernail and toenail loss, viral meningitis, encephalitis, myocarditis, pancreatitis is usually rare because this disease, such as FMD, patient usually will cure by itself for seven 7 days to 10 days. For the treatment and management, usually we will only treat the symptoms. We will give over-the-counter medicine to relieve the fever and pain. The recommended medicine we can give ibuprofen, acetaminophen, and lastly, give adequate fluid. We must ensure the patient is usually kids will have enough fluids, avoid hydration, and if the patient, the kids cannot swallow any fluid, we may hospitalize the patient and give parenteral fluid management. And for the prevention, firstly, hygiene, wash hands, and for kids, we may teach the kids to how to wash hands and clean and disinfect uh, places that usually people come across to. Avoid close contact with a person with HFMD, and avoid sharing of eating utensil, and avoid touching your eyes, nose, and mouth, as this disease HFMD is usually occur from fecal oral route. I think that's all from me. Questions?
Nothing much but one foot mouth, right? So basically, the rash is papules. I was just now, I think when you said, when you saw the rash on the palm, you were saying macular papular is papules, not macular papular. Macular papular, you see a base of red. Is Sasha ready or not? Got questions? Not? No questions? Then see whether Sasha is ready. Is she missing again?
Yes, doctor.
Yeah.
Yes.
Continue.
I'm sorry, doctor.
Yeah.
Okay.
Continue. Yes.
Can I help? Can I have Aisha to help me to present it? Share the screen. Okay. Hello.
Yeah, can hear you.
No. Yeah. Aisha will help me to present the screen.
Yeah, I know. Just start off where you stop just now. I mean, Aisha can project and you talk, right?
Yes. All right. So.
Like clinical features, Aisha.
All right. Okay. So, for example, the clinical features. Okay. So for varicella zoster, the classic symptoms will be the rash will turn into itchy fluid-filled blisters that then will eventually turn into scabs. And then in childhood, usually it will begin with an onset of exanthum. And in adult, usually it will precede with a prodrome of nausea, myalgia, anorexia, and also headache. Okay. And for the disease onset, it usually have a triad of rash, malaise, and a low-grade fever. And a small erythematous macules will appear on the scalp, face, tongue, and proximal limbs with a rapid progression to the papules, clear vesicles and pustules over 12 hours, and subsequent central umbilications and a crust formation. And intense pruritus will accompany the vesicular stage of the rash. Okay, next. Okay. This is basically the evolution of the lesion, where the characteristic of the rash will appear initially as a small red papule that rapidly will progress to the non-umbilicated oval teardrop vesicle on an erythematous base, like what you've seen in the first pictures. Then it will progress into pustule, where it will progress from a clear to cloudy, which the vesicle would be depressed in the center with an irregular border. And lastly, it will form a crust in the center. Okay, next. For the clinical features of the herpes zoster or the shingles, the rash usually in one or two adjacent dermatomes, known as localized zoster, and most commonly it will appear on the trunk along a thoracic dermatome. Less commonly, it will become widespread and affect more than 3 dermatomes, and this is known as disseminated zoster. For disseminated zoster, it's a very rare condition, and it will only infect those who are immunocompromised. And usually painful, itchy, or tingly will precede the rash before the rash onset. And the rash will then develop into the cluster of vesicle, and new vesicle will continue to form over 3 to 5 days and progressively dry and crust. It can have permanent pigmentation changes and scarring at the end of the day. Okay, next. Okay, this is the evolution of the lesions for shingles, where the first picture is showing a group of vesicles that vary in size, which then it will become umbilicated and forming a crust. Next, the third picture is a confluent group of vesicles in a highly inflamed case. And the last picture will be when the vesicle will evolve to crust and may eventually become a scar. Okay, next. For other differential diagnosis, we have the eczema herpeticum or Kaposi varicella eruption. It is a localized vesicular eruption caused by herpes simplex virus that develop on the skin, affected underlying eczema or trauma. Another differential diagnosis such as acute nerve injury, group A streptococcus infections, etc. Next, for the investigations, we have the culture, we have the Zinc smear. Zinc smear is basically to confirm the lesion, either it is hepatic or not, but it cannot be differentiated between either it is varicella zoster virus infections or other herpes virus infections. Then we have the direct fluorescent antibody or polymerase chain reaction. It is basically for the acute diagnosis, and we have the serology test. Serology test like the latex agglutination test, immunofluorescent antibody, enzyme immunoassay, and also the complement fixation. And lastly, we can also have do this chest X-ray. Basically, this is for the pneumonia. Okay, next. Okay, for the complications, first we may have the bacterial infections. Secondary bacterial infections can be due to Streptococcus and also Staphylococcus aureus that usually occurs in 5% of the children with varicella. Next is the herpes zoster. Herpes zoster is a very common complications of varicella that occurs later on in the life. Next is the cerebellar ataxia and encephalitis. These two is a well-described neurologic features that common complication of varicella in unvaccinated children. Okay, and then we have the pneumonia. Pneumonia is a severe complications of varicella that accounts increased risk of morbidity and mortality in adults with varicella. Then we have the post-herpetic neuralgia or PHN. It is a common complication of herpes zoster. that defined as the pain that persists for more than 1 month, and it is very uncommon in children. And then we have the Renzi-Hahn syndrome. Renzi-Hahn syndrome usually occurs because of the involvement of cranial nerve 5, cranial nerve 7, the facial nerve, that can cause facial paralysis. And the last complications, we may have the keratitis or herpes zoster ophthalmitis due to involvement of the trigeminal nerve, cranial nerve 5, the ophthalmic branch, which can lead to vision loss. Next, for the prognosis, the primary varicella usually resolves spontaneously, and the mortality rate usually 2 to 3 per 100,000 cases, with the lowest fatality rate among children 1 to 9 years old. And then infants will have 4 times, and adult will have 25 times greater risk of dying because of varicella. And the mortality rate of untreated primary infection is around 7 to 14% in immunocompromised children, and may approach 50% in untreated adult with pneumonia. And herpes zoster usually are self-limited, especially in children, and have an excellent prognosis in the healthy children. But for immunocompromised children, it may come with severe complications, severe presentations with complications, and sometimes fatalities. So next is the management. Well, I'll be talking. Okay, the first one is the treatment. Treatments, usually we give the acyclovir. Acyclovir usually will be given orally for the uncomplicated varicella, but it can be given intravenously for the immunocompromised patient and also in a severe complication cases of varicella. For oral oxycodone and gabapentin, it is for treatment of acute pain in patients with herpes zoster. And we may also have the surgical care for any zoster complications such as necrotizing fasciitis. Okay, so next, for the prevention, we have the varicella vaccine. Varicella vaccine is a consists of live attenuated varicella zoster virus that be administered subcutaneously. This vaccine is given 2 doses. According to the national textbooks, it will be given around the first dose around the age of 12 to 15 years old, 15 months, 12 to 15 months, and the second doses will be given around 4 to 6 years old. But then, according to Malaysian pediatric protocols, this vaccine will be given around 2 to 12 years old, with separated to more than 4 weeks for the 2 doses. So it can be at any ages between 2 to 12 years old. But this varicella vaccine is very contraindicated in patients with history of anaphylactic reaction, pregnant lady, and also patients with cell-mediated immune deficiencies. And also we have the zoster vaccine. Zoster vaccine is used as a single immunization for the prevention of herpes zoster, and also it can decrease the frequency of post-herpetic neuralgia. I'm sorry, it should be PHN, not HPN. Okay, for the prophylaxis, we have the varicella zoster immune globulin, VARI-ZIG. Okay, this VARI-ZIG is will give a passive immunity for that indicated within 96 hours of exposure in the susceptible individual, like the immunocompromised children, pregnant women, and also the newborns that are exposed to varicella. Okay, so next. Okay, however, there is some controversial issues where the zoster vaccine actually consists of the porcine gelatin, and we know that something that consists of porcine is haram for the Muslims, right? But then the Jakim has decided that the use of the gelatin in medicine is permissible because of the necessity. And up till now, there is still no other alternative substance to replace the porcine gelatin in the vaccine. Thus, this vaccine is still permissible to be used in the Muslim, among the Muslims. Okay, so next.
Sasha, wait. If you're talking about porcine gelatin in the varicella vaccine that we use in Malaysia doesn't have porcine vaccine. Doesn't
Not
have
the
porcine.
varicella vaccine. Zoster, the
Then what?
zoster vaccine.
Sorry? Sorry?
The zoster vaccine consists of gelatin.
Sorry, can you say again?
The zoster vaccine consists of gelatin.
Which booster vaccine?
Yes. I read it on.
Which booster vaccine are you talking about?
For the herpes zoster. I take it from the.
Okay,
Yes,
now.
pardon?
What? The zoster vaccine is for adults, right?
Yes.
Yes. Okay. Now we are talking about chickenpox, right?
Both chickenpox and shingles.
Okay. Now the problem is hello. Okay, the vaccines in Malaysia that is used for children, right? The one that is used for children, none of them contain porcine gelatin. Okay? That's all I'm going to say. All the vaccinations that's used for children in Malaysia, except for the rotavirus one, doesn't contain porcine gelatin. Okay? The varicella vaccine that is used for chickenpox, which is related to the pediatric population, doesn't contain porcine gelatin. Okay? Okay, next.
Okay. So, lastly, this is just a quick review. So, from this, we know that, in short, we know that varicella is the chickenpox or the cacai that usually occurs in children. But then the herpes zoster is the shingles or kayak, which usually occurs in the adult, usually more than 50 years old. So next. Okay, so these are my references. And okay, that's all from me. Thank you. Is there any question? Okay. So
Okay, any questions? Any questions?
None at the moment, doctor.
Okay, if you have, then we just wrap it up now. Can we tetra just
With that, thank you for joining our virology webinar, and also thank you to Dr. Chan for the comments and also improvement. Okay.
Am I supposed to give you the marks, or am I supposed to give the faculty the marks? No idea. Never mind, I'll ask the faculty later. Okay. Bye.
Thank you, Doctor.
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 Thank you, doctor.